to this case. And we'll come back to the case. So in between, if you have any questions, please feel free to ask me. This won't take long, I think about half an hour at most. All right, so this patient is a 65-year-old male. He has BMI, he's obese, his BMI is high, 38. He has diabetes for a long time. His most recent A1C is high, so it's 9.5. No evidence of other microvascular complications. So no retinopathy on the last eye exam. Patient's kidney functions are stable, no albuminuria. His medications include a standard medication regimen that we see in most diabetic patients, metformin, 500 milligrams two times a day, and also glimepiride, which is a sulfonylurea, 2 milligrams 2 times a day. So the patient is here in the clinic for a new visit, and the blood sugars are running high on this regimen. However, when you start talking to the patient, he starts telling you that he's bothered by burning, tingling, and stabbing pain in his feet that is worse at night. Predominantly, so this pain is there and it's worse at night, and it's affecting his sleep as well. He's having a hard time falling asleep, and sometimes it wakes him up from sleep as well. Other pertinent medical history is that he has hypertension, he has anxiety disorder and has depression as well. So he was complaining about these symptoms to the primary care physician. So he was appropriately started by primary care physician on amitriptyline. He does not remember the dose, but he said that although it helped him some, but he had to stop it because he was noticing that his benign prostatic hyperplasia, so he was going to the bathroom more often. He was also noticing some urinary hesitancy and increase in frequency, especially at night, along with a dry mouth. So he used it with some relief and then stopped it. Next slide, please. All right. So he's in the clinic, and then you start your examination. You do a vibration sensation testing using a 128 hertz tuning fork, and I'll show you how this exam is done. But when you do this, so that's one part of the exam that you do it, and the whole idea of doing this exam is to see if they have diabetic sensory neuropathy or their vibration sensations are intact. So we did this exam on him. And it was low, indicating that he does indeed have problems with sensory perception, and the proprioception is affected. Then we did a 10-gram monofilament testing on him, and it showed that his sensations, he was unable to feel that sensation on his toes, so that was also affected. The big toe dorsiflexion, so if you ask them to flex his foot and the toes, there was weakness on both sides on the big toe dorsiflexion. So he was unable to bend his toes, and the ankle reflexes were negative as well. So all of this tells you that there is some problem in the sensory component of his exam. Maybe some weakness in the muscles as well, because he was unable to flex his big toe as well. No calluses was noted. So the question here is, how should this patient's diabetic neuropathy be managed? Because it's clearly bothering him in terms of symptoms, and it's also affecting his quality of life, meaning his sleep is affected. If the sleep is affected, he will be tired during the day, then you don't expect the patient to exercise or follow whatever exercise regimen you're going to discuss with him. So it is affecting his diabetes. Possibly his diabetes is affecting his symptoms and is affecting his quality of life. So how should this patient be managed? So that's the question. Next slide. So we'll now talk about the diabetic neuropathies and an approach. So diabetes can affect all components of the nervous system, but predominantly it starts with the sensory component. So if you see here on this slide, it just shows that there is a progression. So the sensations, the touch, the tactile sensation, the proprioception is affected first, and then it progresses to the autonomic nervous system. So meaning you're swallowing, the GI movements, urinary symptoms, heart rates, which is part of the autonomic nervous system, and we will talk about this as well. And if this progresses even more, then it can cause muscle dysfunction as well. So muscle wasting, sarcopenia is also common with diabetes. But most patients, by and large, we see a great majority of the patients, and I'll give you some numbers here, have sensory component dysfunction. So they have a sensory neuropathy, but they can develop autonomic neuropathy as well, and then motor or the muscle function can be affected. And as the diabetes progresses over a period of time, all these functions can be affected. Next slide, please. So these are some of the components of the sensory neuropathy, which is the most common. So if you see here in the first picture, this is the most common type of neuropathy that we see, and this is called the distal sensory peripheral neuropathy, or DSPN. So if you see here, the longest, the nerve fibers that are furthest away from the brain, so the legs, the toes, the hands are affected first, and it progresses. So it starts in the toes predominantly, and as the disease progresses, it starts going up. So this is a typical glove and stocking pattern that we talk about with distal sensory neuropathies. This is the most common, and this affects most diabetics. And again, we will talk about these numbers as to how many patients can have this. So distal sensory neuropathy, which is the most common type of sensory neuropathy. Then we have the autonomic neuropathy. So autonomic nervous system is part of the nervous system that is not under our control. For example, when we swallow food, we bite and then we swallow, and then all the rest of the movement of the food through our digestive tract is managed by the autonomic nervous system. Our breathing is managed by the autonomic nervous system as well. Heart rate also is managed by this. The urinary and the bowel habits is also on the part of the autonomic nervous system, most part of it. So diabetes can affect that as well. So therefore, it's not a surprise that some of our patients will have gastroparesis. They will have complaints of nausea, vomiting, constipation, urinary symptoms, sweating as well. We will talk about this. So this is also affected in diabetes. So this is also part of the autonomic nervous system neuropathy as well. Mononeuropathy. Now, mononeuropathy means one nerve is affected, just one nerve, rather than multiple nerves like here in the distal peripheral sensory neuropathy. And this we see, actually, it's not very common, but this is more common in diabetic patients. So the examples of these neuropathies are your carpal tunnel syndrome, where this just the median nerve is affected, or the tibial nerve, as you see here highlighted in blue, that is affected. So patient is complaining of just one pain area in one area, one part of the body, because of that one nerve is affected. And then sometimes the facial nerve paralysis or the Bell's palsy is more common in diabetics, oculomotor nerve, and we will talk about. So that's a sensory neuropathy, and it's called mononeuropathy. Then you have the proximal neuropathy, and this is just a few nerves in one zone is affected. So these patients will have just inflammation of the nerves here, and it will cause significant pain in this area. It will almost sound like a fracture, but when you do the x-rays, everything will be normal, but they will be having pain here. Sometimes the patients can develop the myotrophy or significant muscle and the nerve pain in just one location. These patients will, and these the neuropathies develop suddenly. Whereas the first neuropathy, the distal sensory neuropathy, is a slow, progressive problem. So it starts with just the toes and progresses. These mononeuropathies and proximal neuropathies can happen suddenly. So the patient can wake up with these complaints all of a sudden, and we'll discuss these two neuropathies. The most feared proximal neuropathy is the amyotrophy, in which the proximal muscle. So these patients will be unable to walk because of this significant neuropathy. But here today we will be talking about the peripheral sensory neuropathy, which is the most common type of sensory diabetic neuropathy. Next slide, please. All right, so I said DPSN, or the peripheral distal sensory neuropathy, again starts in the toes and in the hands and progresses slowly. This, as I said before, is the most common type of diabetic neuropathy. These numbers are very interesting because it's very common. About 1/3 or more of our type 1 and type 2 patients will have this neuropathy by the time they are diagnosed. So this starts early and starts affecting the nerves at a very early stage. And even more important, even if the patient has just impaired glucose tolerance, meaning they have pre-diabetes or their blood sugars go up after eating a meal, up to quarter of these patients, so 25% of these patients, will have some form of distal sensory neuropathy. And this has been proven in research studies. So in pre-diabetic patients, they actually did biopsies under the nerves, under the skin. So they did nerve biopsies, and what they noticed was there was a reduction in the intraepidermal nerve fibers. So the volume of the nerve fibers had dropped in these patients, even if they had just a pre-diabetes. So it's very, very common. And the sooner we start dealing with it and start making it a priority of treating it, their diabetes, and asking them questions about it, the sooner we can diagnose and teach our patients more about it so that we can prevent this from progressing, because this is a progressive condition. It will start slowly and then affect more and more area of the body. All right, next slide. So what kind of symptoms will these patients complain of? And this is very important, because when we need to know this so that we can ask the right patient and the right questions to these patients. Okay, so the first is, so the symptoms can be divided into negative symptoms, meaning the symptoms that they're not complaining of, or the feelings that they don't have, and the positive symptoms, meaning the symptoms that they're actually complaining about. So positive symptoms are the symptoms that they are actually experiencing. So like in the case here, some patients will complain of burning, tingling, stabbing pain, and allodynia. So allodynia is, things that will not actually bother us, or we do not conceive the touch as pain. For example, if these patients are in bed and they're sleeping and the bed sheet covers their toes, it will cause pain. Normally, it will not be perceived as a pain sensation, but because of the neuropathy, they will develop this allodynia, which is the misinterpretation of an external stimuli. So a bed sheet is covering them, is causing them burning and pain. So these are some of the symptoms, and these are the positive symptoms. Now, the negative symptoms are the lack of symptoms. So when you touch these patients, and when you check for any sensation with a tactile stimuli, when you touch their toes, they will not be able to feel it. You will also notice weakness on the muscle movements, like we saw in that patient. So the negative symptoms actually put them at risk for developing calluses, corns, ulcers, and eventually infection. So the negative symptoms are actually not bothering the patient that much. I mean, they are sleeping at night, okay, but this is where we come into play, and we want to check for that to see if they are developing these problems, sensory loss, and if they cannot feel a sensation, then if they develop a small cut or an opening, then they won't feel it until it becomes infected, and they will present later. So negative symptoms is what we want to screen for by our examination, and we will talk about it. In positive symptoms is actually we want to ask them questions about, do you feel burning in your toes, or does it hurt at night? And why at night? Predominantly because these patients are in bed, they're resting, they're not busy, and that's when it causes their brain can perceive this as coming from the toes. So that's why most patients complain of these symptoms predominantly at night. So positive symptoms, negative symptoms. We ask about the positive symptoms and we screen with our testing with the negative symptoms. If the patient has distal sensory peripheral neuropathy, which is the glove and stocking pattern, then their risk of developing an ulcer increases by about, a lifetime risk increases by about 15 to 25%. So if a patient has it, there is a 15 to 25% chance that they will develop an ulcer. Not everyone will develop an ulcer, but they can develop an ulcer, and that's where foot exam, telling the patients to maybe buy a mirror, put it under their foot, and look at their feet to see if they're developing any ulcers or calluses. Going to the foot doctor and having it shaved will prevent this. Also, the sensory loss will cause problems with their gait, and that also increases as they age their risk of fall and eventually fractures. So, with aging, we all lose muscle, especially our elderly population. And if they're already have a problem with their sensation, then that can lead to increase in the fall risk. So that is something that we, gait training and exercise and physical therapy can become important if we feel that they are a major fall risk. And of course, if they cannot sleep at night and they're burning and tingling at night, that can affect their sleep and therefore their quality of life. So that is important. Next slide, please. All right, so what are the risk factors? So identification of the risk factors is important so that we can treat the risk factors and prevent the progression. So the most common for distal sensory peripheral neuropathy is a poor diabetic control for a long period of time. High blood sugars will cause inflammation and swelling around the nerve, which will cut off the blood supply to the nerve and will eventually cause necrosis or nerve damage. So long, if they have prolonged history of uncontrolled diabetes, that's the number one risk factor. And this is important, increased range of variation in glucose. So for example, if a patient's blood sugar ranges from 400 to 200 to 400 to 100, so the wider the variations in the blood glucose, the more the chances that the nerves will be affected, because they will develop swelling, the swelling will go away, then it will happen again. And these fluctuations are actually more dangerous. So sometimes our type 1 diabetics, which are actually, their blood sugars are, we are seeing peaks and troughs all day long. Although they have a short history of diabetes, they are more at risk for developing diabetic neuropathy. So that's the second risk factor. Aging, as with advanced age, as we age, the nerve fibers actually decrease, the regeneration potential in these nerves go down as well. So they, and of course, the more the older you are, there's a likelihood that you have had diabetes for a long period of time. That's also affects it. Obesity, by causing insulin resistance, affects it. Of course, smoking is patients who smoke, they are at increased risk for developing diabetic neuropathy. Hypertension, high blood pressure, because the vessels that supply the nerves, if there is a high pressure, then it can cause microinfarction and can cause the nerve damage as well. Hyperlipidemia or high cholesterol, by causing atherosclerosis in the smallest of the small vessels that supply the nerve fibers, can cause it. And peripheral arterial disease, similarly, if you develop an ulcer and if you have blood flow to that area, it will increase the risk of infection. So these are some of the risk factors that can cause, that can increase your chances of developing painful neuropathy. Next slide, please. All right. So, how should we examine these patients? So we in the clinic normally have most clinics have this 128 Hertz tuning fork, and this is to check for the vibratory sensation. So we make the tuning fork vibrate. Can you please, the next slide, I think there's a picture. Yeah, all right, perfect. So if you, so this is the Fleming testing first. So this is a monofilament. And what we are doing here is we are checking the sensation. So we are putting this filament and we are putting it on all these pressure areas. And we apply enough pressure to make it bend. And we ask the patient to close their eyes and see if they can sense it. If they cannot sense the touch, then that means the sensation, the nerves that carry these sensations up the leg to the brain are affected, and that means the nerves are affected from distal sensory neuropathy. Most clinics have this 10-gram monofilament, which we normally carry. It's a disposable thing. You just touch them. I normally start it with their fingers because they can feel most of it. So I ask them, okay, can you feel the touch? And then I ask them to close their eyes there and then touch the sole of the foot and see if they can feel it. Also with examination, we should check the pulses. So the posterior tibial pulse, which supplies the foot, if there is a loss of pulse or the pulse is weak, then this means that they may have peripheral arterial disease as well. We see for the presence of hair on the leg, if they're losing hair or they're not growing hair on the toes, then this can indicate neuropathy. And also poor blood flow. Capillary refill is another thing that you can do. You should pinch the nail bed and then let go of it and see if they can reestablish the color within less than 2 seconds. If you please click, yeah. So this is how we use the tuning fork test. So we make the fork vibrate and we put it on the bony part of the foot. So mostly on this, either on the medial malleolus, on the ankle area, or on the head of the big toe here. And we ask them to tell us as soon as they stop hearing the sensation. So if they feel the vibration, as soon as they stop feeling the vibration on the bone, that's when they need to tell us. So most patients, most diabetics will lose this sensation early in the disease. And so this is what we need to check, because these are the negative symptoms. And if they are positive, then these patients are at increased risk. And I mentioned the lifetime risk goes up to 25%. So foot examination, seeing a podiatrist, make sure that they have the correct footwear, wide-based shoes, and to prevent these calluses will become very important. So this is the examination. This is the 10-gram monofilament testing. We check it on all these pressure areas and the vibrating tuning fork. All right, next slide. Yeah, thank you. All right, so some of the tests, I think tests are really low yield. Most of this is a clinical and your examination based diagnosis. Besides checking their blood sugars and preventing the variation in the blood sugar, there's some other tests that you can do. But I must say these tests are low yield, and they really, if you have diabetes, it's most likely from it. But we want to make sure that other problems are not contributing to it. So we check for thyroid, sometimes hypo or hyperthyroidism can also cause nerve damage. Similarly, B12 level. I think of all the tests, we normally check B12 because B12 deficiency can cause polyneuropathy, which can look like peripheral diabetic neuropathy as well, especially in patients who are on metformin for a long period of time. Metformin can lower your B12 level. So if you are seeing a patient with neuropathy and on metformin for a long time, I think it's a good idea to check B12 level. If you already have a CBC, then that's very helpful because B12 deficiency and folic acid deficiency mostly causes macrocytosis. So if their MCV is high, this will also direct you to that to check for the B12. Ask about alcohol use as well, because alcohol can also drop your B12 levels as well. Now, serum immunoelectrophoresis is recommended to check for any inflammatory demyelinating neuropathy to make sure that they don't have any other condition. So serum immunoelectrophoresis can be done, but I normally reserve it for patients who are not responding to treatment, and to make sure that they don't have anything unusual. I do not normally order it as a first line of testing. Next slide, please. All right, so after sensory neuropathy, so these are some of the autonomic neuropathies. So our heart rate is controlled by the autonomic nervous system, and as we change position, normally what happens is the heart rate goes up, so the heart can pump enough blood to go to the brain, and we don't feel dizzy because of it. However, despite this is autonomic part of the nervous system. So our patients with diabetes sometimes report dizziness on standing up or lightheadedness on standing up. Or so what happens in them is their heart rate normally does not respond to the changes in position. And this is called CAN, or cardiac autonomic neuropathy. It is a very difficult diagnosis because sometimes medications can cause it. Dehydration, which can happen from hyperglycemia, can cause it. So to make the diagnosis, we have to use a high index of suspicion that their diabetes and their autonomic neuropathy is contributing to some of the dizzy spells and passing out that they are experiencing. So these patients will have dizziness predominantly on standing up, not when they are sitting down. A change in position, especially if they are dehydrated or on certain other medications, it can exacerbate it. So cardiac autonomic neuropathy. I think the gastrointestinal autonomic neuropathy is what we worry the most about, especially with the gastroparesis. So they will feel full, they will feel that the food is getting stuck as they eat, they don't have a good appetite, their stomach emptying is slow, which can also cause wide variation in their blood sugars, because they will take insulin. Insulin will only last in the system, short-acting insulin, 4 hours, and the stomach is emptying slowly. So these patients will tell you that the Novolog or the Humalog is not working, because when I take it, my blood sugars are still high after 6-7 hours. And that is because the Novolog is out, and now they're absorbing food and the blood sugars go up, which will eventually make the neuropathy even worse. So it's a difficult condition to treat, and it can cause wide variation in blood sugars. Similarly, the autonomic nervous system can affect and can cause urine retention, urinary symptoms, including urinary urgency and hesitancy. And of course, we know that in male patients predominantly, it can cause problems with achieving and maintaining erections by affecting the sympathetic and the parasympathetic nerve supply to the genital area. So erectile dysfunction is very common in diabetics. Next slide. The sweating is also controlled by the autonomic nervous system, and sometimes these patients will complain of hyperhidrosis, meaning they sweat a lot. So there is abnormal sensation when they heat up. When in hot weather they start sweating profusely, or when they walk short distances they start start sweating profusely, and that's hyperhidrosis. When we see patients sometimes with complaints of that they're sweating a lot, we screen them for diabetes besides checking growth hormone and other thing. And the other thing that can happen is the exact opposite of hyperhidrosis, which is anhidrosis, meaning this stops sweating at all. And this, especially in the lower extremities, if they're not sweating, then will lead to dryness. Dryness will lead to cracking of the skin and can further increase their chances of infections. So that's why applying cream on the feet at night will help prevent the dryness. Hypoglycemic unawareness, we are familiar with that. So this is where when our blood sugars normally drop, the body will mount all the stress responses, cortisol, growth hormone, glucagon. And that part is also controlled by the autonomic nervous systems. Patients who have had significant neuropathy and frequent hypoglycemia, they will not be able to mount that response, and they cannot sense the low blood sugar. So they will not develop palpitations or sweating, nervousness when they develop hypoglycemia or low blood sugar. So they will be very low by the time they will become aware of the low blood sugar. So all of these complications are very significant. They affect the quality of life, and they affect their diabetes indirectly by causing these complications. Next slide, please. All right, so mononeuropathies. Can you click next again? All right, so this is one mononeuropathy. Like I said before, mononeuropathy is one nerve affected. So this patient, if you look at the pupil, the left pupil, it's actually not in the center, it's looking down and out, it's also dilated. So this can develop suddenly. This is an oculomotor, the third cranial nerve palsy. So the pupil will be looking down and out. And this is, like I said, it can happen suddenly. So out of the blue, it will happen. This is very common in diabetics. And this is because of the blood flow to that oculomotor nerve is affected. It's mostly one eye, and they will be complaining of double vision. So that's the most common complaint. Press next slide, please. All right, so this is your Bell's palsy. Again, this is a mononeuropathy. You see one side this time, the left side of the face is completely flat. There is no, frowning on the side. He cannot close his eye, and the nasolabial fold is completely flat. So this is a facial nerve, or the seventh nerve paralysis, which is also diabetic neuropathy. Press again, next slide again. All right, and this is so the patient is trying to look on the side. This eye is working fine. The patient can look towards that side, but because of the paralysis of the lateral rectus nerve, the patient cannot look all the way to the side, and the eye is maintaining, staying in the center. So this is because of the nerve paralysis as well. And this is the sixth cranial nerve palsy, which is a mononeuropathy. Just that one nerve is affected. So this is also common in diabetics. Next slide. All right, so this was the fourth type of proximal neuropathy that I mentioned. And again, this is very severe. The pain here is very severe, and it's only localized to one area. It's not in the toes. It affects the bigger group of muscles, so thighs, buttocks, hip, abdomen sometimes, and chest they can develop significant pain. And it's typically on one side, so it's not a bilateral disease like the distal sensory peripheral neuropathy. And it can cause not only severe pain, but it can cause severe muscle wasting as well. So sometimes when these patients develop this neuropathy, they cannot walk, and they become bedridden, and it's a difficult condition. It's important to make the correct diagnosis and send them to a neurologist and for physical therapy, because some patients are treated with IVIG, intravenous immunoglobulins, and high doses of steroids. So the sooner we make the diagnosis, the more we can prevent the muscle wasting and move the patient to the right provider. Next slide. Okay, so this is just to differentiate between the different neuropathies that we have talked about. The last one you see, the peripheral neuropathy, is like I said, it's gradual. It starts slowly. It's bilateral. It's meaning both sides are affected. It's a symmetrical polyneuropathy. In contrast to the neuropathies, which is mostly single nerves, and it develops suddenly. The facial nerve paralysis, the oculomotor, and the abducent nerve, this resolves spontaneously. So we just need to reassure the patient that as the swelling goes down, it will resolve on its own. Of course, if they have diplopia, then we give them a patch and other things, but most of the times it resolves on its own. Whereas distal symmetrical neuropathy, we need to treat the diabetes and other things to control this. Next slide. Okay, so management. So what are some of the things that we can offer them? The first thing we can do is, I mentioned that obesity, diabetes, weight fluctuations can affect that. So diet and exercise regimen are helpful. And these two things are actually increase the number of nerve fibers. And this was proven on biopsies. The intraepidermal nerve fibers, so the nerve fibers under the skin, actually increase with better diet, low carb diet, and also with different exercise programs. So the more they walk, the more they're doing exercise, these nerve fibers will actually increase. So they can help these neuropathies. Of course, if they're falling and they have gait and balance problems, then gait training and balance training will help them. Tighter diabetes control. So what we want to do here is we want to bring the blood sugars down slowly. That's very important. And what we want to prevent is the wide fluctuations from 400 to 200. That's what we want to minimize. So here, if we use a sensor, for example, a freestyle or a Dexcom sensor, then we can understand their variations more easily and ask the patient to prevent the wide fluctuations. On the other hand, if we bring the blood sugars down too quickly, meaning an A1C drop of more than 1% in less than a month, this can actually worsen the neuropathy acutely. However, this is self-resolving. Again, this is because of the edema that develops around the nerve fibers and causes the neuropathy to worsen. So sometimes when we are treating these patients, we tell the patient, look, your blood sugars are high, which is contributing to it. So we want to bring it down slowly. So there are no prizes of dropping the blood sugar from 400 to 100 in 1 week. We don't want to do that. So initially we set up a target of around maybe 200 for the first 2 weeks, then maybe 150 and slowly bring it down. So always start, if you're starting insulin and aggressive regimen, start slowly because you're not going to help the patient. And sometimes these patients, they start having more pain and they feel worse. They will stop the treatment. They said they will feel that the insulin is actually causing that problem, although this is the blood sugar coming down that is causing the problem. So you tell the patient in advance and you go slow. If they're smoking, they will also benefit them if they're not smoking. Next slide, please. Click next slide. Okay, so the pharmacotherapy. So this is besides all the other things that we've talked about. So we can use a class of medication called the tricyclic antidepressants. So these are some of the names of these medications. I want to concentrate on this, on the side effects. If you see here, it can cause sleepiness, dizziness, dry mouth, and also tachycardia. It can cause urinary retention. And I mentioned some of the diabetics will have these problems anyways. Urinary retention can happen with them because of the autonomic neuropathy. So these medications do have side effects. So this is one class, and in our patient, if you remember, the patient was started on amitriptyline by the primary care physician, and then he developed urinary worsening of his BPH symptoms by increasing, because of the antimuscarinic side effects, the bladder was unable to empty properly. Next slide. The other class of medication that we can use in these patients is the mostly the SNRIs. So this is a serotonin norepinephrine reuptake inhibitor. Duloxetine or Cymbalta is used predominantly. If you look at the side effects, again, it can cause nausea. So if the patient already has gastroparesis and they feel nauseous, it can get worse. Sleepiness, dizziness, and anorexia can also happen. Next slide. Next. All right, anticonvulsants. So these are some of the medications that are also used. Neurontin is, I think, by far the most commonly used medication. Again, the side effects, confusion, ataxia, dizziness. So if they are already a fall risk, it can make the fall worse. We have Lyrica or pregabalin. Also look at the side effects again, edema, confusion, weight gain. Some of the other medications that can be used is trileptal or carbamazepine, although I must say that it has a lot of side effects and it can cause a lot of other problems, so we hardly use it. And Topamax, which is topiramate, can also be used for this condition. Next slide, please. All right, and last resort, we use opioids, which is oxycodone. Sometimes we use the tramadol as well. However, this is the very, very last resort for this kind of thing. All right, next slide. And this is interesting. In some cases, sometimes if the patient has mild symptoms, then I ask them to use the capsaicin cream at night, and this will cause some local irritation, and after that they will stop. They will not feel the pain that is causing them. So if I'm worried about the side effects, especially fall and dizziness and all that, then that may be an option. Just using the capsaicin cream, starting at night, and then see how they respond to it. And then, if they like it, and there are few side effects other than local irritation, so that may be an option, using capsaicin cream over the counter to apply that on the tooth. Next slide. All right, so this is just a summary. I think I wanted to highlight a few things here. First is, the name of the medications, and then the number needed to treat, NNT, if you see here, for 50% improvement in the symptoms. So how many patients we need to treat in order to cause 50% of them, to cause 50% improvement in their symptoms. So if you see here, the start, these are the only two medications that are FDA approved for neuropathy. We use a lot of Neurontin, but this is not an FDA approved indication for gabapentin or Neurontin. So the two medications are the Lyrica, which is a pregabalin, and look at the doses. Initial doses are it's a TID dosing. We start at a low dose, 25 to 75 milligrams, and then titrate the dose. And this is the effective dose, 300 to 600. And the number needed to treat for 50% improvement is 7.7. Neurontin, if you see here, so we start at a very low dose, but this dose can go very high, almost 3,600 milligrams per day. Cymbalta or duloxetine is the other FDA-approved medication. It's a once a day. This is the advantage. It's just taken once a day. We start at a low dose and then increase the dosing. SNRI, or which is the Effexor or venlafaxine, can also be used. It's once a day, but it is also not FDA recommended. Similarly, Elavil or amitriptyline is not FDA recommended for this. I mentioned about the topical capsaicin. The number needed to treat here is, worse than every other medication, but this probably has the least side effects. So this may be a good start in the mild cases. Next slide, please. All right, can you press next again? Next again. All right. So this is just, it looks very complicated, but it's really, what we need to do is, first of all, we need to identify what kind of neuropathy they have. If this is a mononeuropathy right here, so then these patients will improve on their own. If they have distal symmetrical polyneuropathy, which is right here, then we need to see what is their patient profile. Do they have problems with falling asleep? Because if they cannot sleep, then we want to use a medication that actually has a side effect of sleepiness or somnolence at night, especially. If they have anxiety disorder, then we want to use a medication that will also help their anxiety and depression. So for example, for sleep, Neurontin and Lyrica or pregabalin can help them actually fall asleep. So it will help with the nerve pain, neuropathy pain, and it will also help them with sleep. If they have anxiety as a comorbidity, then certainly using a medication which helps with their anxiety will also help. If they have depression, then choosing an SNRI or an SSRI, which actually helps with their anxiety as well. So it all depends on what the patient profile is when we are deciding to choose a medication that will help both the things. Next slide. All right, so now we are coming back to the case. So if you see here, this patient is obese. His BMI is high, so we know if he loses weight, this will help. His A1C is clearly high, 9.5. He is just on 2 medications, and he's complaining of positive symptoms, right? So he has tingling, stabbing, worse pain at night. His sleep is also affected. He has anxiety and depression. So when we are choosing an agent, we have to look at all of these things. He was already on amitriptyline, was stopped because of the worsening of his BPH, although it was helping some. Next slide. Click, please. All right, so the first thing we can ask him to do is to weight loss, and we will do all of these simultaneously. So that will help him because his BMI is high, and we know that the exercise program, weight loss, will cause the nerve fibers to actually grow back. And next, press next. Exercise program, same thing. Next, please. All right, reduce the glycemic variability. So we don't want the highs and the lows. We want the blood sugars to be in a tighter range. And slowly bring it down. So maybe using a Freestyle Libre sensor or a Dexcom sensor just to help understand how much variations there is. Next slide. All right, check his peripheral pulses, make sure that there is no undiagnosed peripheral arterial disease or the PAD, because that will also affect his symptoms. So if that's the case, then maybe sending him to the vascular clinic for testing will be indicated. Next slide. All right, so the two attractive options for this patient because of history of anxiety, depression, and sleep problems will be Cymbalta, which will help with this anxiety and depression, and also pregabalin, which has the option of, which has the side effect actually of sedation. And if we can give this medication, it will help. However, the Cymbalta of the two causes sleep fragmentation issues. So they do not go into the REM sleep that much. So between the two options in this patient, because he's having sleep issues, and also has some anxiety, depression. Lyrica may be a better option, which we said we started at 25 milligram twice a day or thrice a day, and then increase the dose. Next line. All right. So Neurontin also is an option because it can cause sedation. However, weight gain is one of the side effects. Most patients on Neurontin, especially at high doses, gain weight. That's one of the side effects. We are asking this patient to lose weight, so Neurontin may not be the best option. Next slide. All right, so we started him on pregabalin based after discussing the side effect profile, 25 BID, then increased to 3 times a day because we don't want him to be too sedated, lose balance, and fall down. So start the dose slowly and escalate, and then titrated the dose. Now the patient is on 100 milligrams 3 times a day. And of course, we check on the side effect, make sure that he's not too sleepy during the day or has dizziness. These are all the side effects of Lyrica or pregabalin. Balance is okay, and the symptoms are improving or not. Next slide. So these are the medications, and this is what we do now. This is something rather new. It's called the HFX treatment. Here, a stimulator is placed into the spinal cord, and what it does, it decreases the pain sensations that are carried by these peripheral nerves to the brain. It is an outpatient procedure. This is actually offered at WVU Pain Clinic. So if we have tried medications, if they cannot tolerate medications, if they have side effects on the medication and their neuropathy is still affecting their quality of life and their sleep and the anxiety levels, this can be an option. By sending them to the pain clinic, they will evaluate the patient, see if the patient is a good candidate. And again, this is a subcutaneous device, just like a pacemaker that is placed here, which actually blocks the nerves that carry these pain sensations to the brain. I have one patient I started recently. I've sent that patient there, and I was very impressed with the improvement. Next slide, and that will be the last slide. So if you see here, this is the these patients. This is their pain score, meaning how much they were affected on a scale of 0 to 10. So their pain score was 7.7, so almost 8. Before this HFX treatment, and after that, without any medication, just by this stimulator, which is actually decreasing the perception of pain going to the brain, it dropped from a score of 8 almost to 1.7. So significant improvement. So if the patient cannot tolerate this medication and it's affecting the quality of life, this is certainly something that can be looked at and is an option. And I think this is my last slide.
Excellent. Thank you so very much. That was really well put together. Had some good graphs, great side effects, and information for everyone to share. Does anybody have any comments or questions regarding this topic or anything else? With that last treatment option, can an individual just request that, or do they have to go through medication, like oral medication route first?
Yeah, no, I think that can be done. It all depends on how bad their symptoms are and what they have tried first. If it's a mild, case, then certainly we can start with the medication first and see how they respond to it, because the medication may help with their anxiety and other things as well. But if they have already tried it or they cannot take it, then certainly that is an option, the FHX treatment.
That's excellent. Thank you so much. Any other questions or comments? And thank you so much for including a slide, case slide in there as well. Please remember to turn in some cases to us. That really does help the discussion portion of ECHO. All right, if there aren't any questions, I'll just make that final announcement. And the next session we'll have will be September 14th with Hugh Quinn discussing common medication classes and when to use them. Again, thank you so much for your time today, and you guys have a great rest of your week.
Thank you.
Bye-bye.